Welcome to our panel session today. We're very pleased to have you. In particular, we're pleased to launch this inaugural Dr. Richard N. Merkin Distinguished Speaker Series with two very distinguished speakers, Jay Bhattacharya and Sten Vermund. We're especially grateful to Dr. Merkin, whose philanthropic leadership and commitment to improving healthcare have made this speaker series possible. His support helps the Schaeffer Center continually bring together prominent policymakers, experts, and industry leaders to discuss some of the most pressing problems in healthcare facing the United States. My name is Darius Lakdawala. I'm the Director of Research at the Schaeffer Center, and I'll be moderating this discussion today. Today's topic is public policy and COVID-19, the path forward. And today we're going to have a discussion with our two guests, Jay and Sten. Audience members can submit questions at any time using the Q&A feature at the bottom of your Zoom app. We'll be discussing public policy from a range of perspectives and the best strategy for dealing with COVID-19 in the coming months. Let me begin with the brief introductions of our two distinguished speakers, and I will not be doing justice to their lengthy CVs, but let me begin with Professor Jay Bhattacharya. Jay is a professor of medicine at the Stanford University Center for Primary Care and Outcomes Research and the director of the Stanford Center on the Demography and Economics of Health and Aging. He also serves as a research associate at Acumen and the National Bureau of Economic Research. And apart from those minor appointments, Jay is a senior fellow at the USC Schaeffer Center. Jay's research focuses on the constraints that vulnerable populations face in making decisions that affect their health, as well as the effects of government policies and programs designed to benefit vulnerable populations. So Jay, welcome and thank you for being here. And next I'd like to introduce Sten Vermund. Sten is the Dean and Anna M.R. Lauder Professor of Public Health at the Yale School of Public Health. Dr. Vermund is a pediatrician and infectious disease epidemiologist focused on diseases of low and middle income countries. Dr. Vermund has become increasingly engaged in health policy, particularly around the sustainability of HIV/AIDS programs and their expansion to non-communicable diseases, pandemic respiratory disease response and prevention, and public health workforce development. Since the advent of the novel coronavirus epidemic, Sten's work has engaged colleagues in China and also locally in Connecticut for pandemic response. Welcome, Sten, and thank you very much for being here as well. Let me begin. I'm going to dive right in because everyone wants to hear what both of you have to say about this timely topic. And I'll begin, Jay, with you and some bigger picture context for everybody. Jay, you had gone on record early in this pandemic arguing that infections and immunity were already quite widespread and mortality was less than feared from COVID. Since that time, which seems like a lifetime ago to all of us, I'm sure, we've seen multiple waves of infection, the discovery that COVID results in some cases of long-term morbidity, unpredictable variation in mortality risk. With the benefit of hindsight and new evidence, Jay, has immunity been less widespread and mortality more significant than they might have initially appeared? And maybe also more to the point today, are we indeed looking at the prospect of a dark winter of COVID spread?
So thanks, Darius. So in March, when I first started thinking about this more seriously, I had thought about the H1N1 epidemic, where seroprevalence studies, that is studies of antibody prevalence in the population, found during the 2009 H1N1 epidemic that the disease actually was quite a bit more widespread back then than the number of cases would have suggested, that is the number of identified cases. And the hypothesis I had was that similar thing was true in the context of COVID. And I did three different studies early in April, all of which found basically the same thing. So about 40 times to 50 times more cases in California. Infections than cases in California. Now, part of that was that we weren't testing as much back then. So, you know, in order to identify a case, you needed to have a case, someone being tested. We were testing like severely ill people as opposed to sort of asymptomatic people like we're testing today. That result in some sense wasn't surprising. It turns out to be true, actually. So now, since then, there have been about 50 some studies like that, or more actually now, that have been done around the world. And the infection fatality rate that have come out of those studies, again, 50 some, is for people who are under 70, the disease has a 99.95 survival rate. Infection survival rate, 99.95% infection survival rate for people under 70. For people over 70, it's a much more deadly disease, somewhere on the order of a 95% infection survival rate. So in that sense, it is so just to give you some sense of scale, in Santa Clara County in early April, there were 1,000 identified cases, and we estimated there were about 50,000 people who had been infected to date in Santa Clara County in early April. There are 2 million people who live in Santa Clara County. Since then, it's spread for certain much more widespread than the 1,000 that are identified, and certainly more than the 50,000. My estimates, based on what I've seen so far in the United States, for instance, is that I think there's something on the order of 10.5 million cases identified to date. Most likely, the number of infections is on the order of between 70 and 90 million, based on the multipliers and the seroprevalence studies I've seen out of the United States. Now, we don't know for certain because we don't have a national seroprevalence estimate or sort of a systematic set of way to track that. But I mean, between between 70 and 90, that means somewhere between a fifth and let's say a fourth of the American population have been infected. How far does the infection have to go? I mean, that's still to be determined, but I do think that we are in for a time where the disease is going to spread as people sort of move indoors.
But your prediction is that at least if we successfully protect the elderly, I think you made that point about people over the age of 70, that's the strategy we have to pursue in order to avoid a particularly troubling mortality outcome.
Yeah, I mean, that's the result that I look for to see if a policy or an area has been successful. I mean, the death rate really is the key thing. And we have a very good sense from a whole series of excellent studies now about who really is vulnerable. I mean, age is the most important risk factor, but there are others like diabetes and other chronic conditions. Policies that protect the vulnerable are successful policies to me. That's the number one criteria I will look for seeing if a set of policies have worked or not.
Thanks, Jay. So, Sten, I'd love for you to respond to that, but I also have kind of a related angle that I'd like to get your thoughts on. So early in the epidemic, Sten, you spoke, I think, quite presciently about a parallel humanitarian and economic crisis that would transpire alongside the public health crisis. And indeed, emerging evidence suggests that our efforts to contain COVID are causing their own negative consequences in a variety of ways. And our fights against other diseases, the reduced use of routine care, elective procedures, not to mention the economic dislocation and the humanitarian costs that brings with it. So, Sten, from that perspective, do you think we as a society have focused too much on COVID deaths and morbidity to the exclusion of other health costs and humanitarian costs? Did we overreact or maybe overfocus on COVID deaths in your view? What are your thoughts on that? And how does it also inform your views on what we ought to do today and what we should expect over the next few months?
Darius, that's a great question. The reality is that if we had been more efficient and more effective at pandemic response, the way that China and South Korea were, we'd be so much better off because our society would be relatively COVID-free and we would be back to work. The reality is our indolent response and our relaxed approach to the preventive measures that are immensely familiar to us in respiratory disease prevention, the fact that we've been undisciplined as a society has led to the worst of both worlds. Not only are we seeing, 120,000 cases a day, each day for the last 2 weeks practically, over 11 million cases, flirting with 250,000 deaths. we're going to have 40 people die just in the time that we have this conversation. So we not only have not controlled our pandemic, but we've also compromised people's ability to make a living, go to school, feed their families, support their small businesses, whatever it is. So we've sort of done the worst of both worlds. And for my money, as an epidemiologist, I would have loved to see an efficient and effective and disciplined national response where masks would have been used in March. We would have had physical distancing. We would have had selective closure in highest prevalent zones. We would have made preparations for stay at home in lower prevalent zones so we could have turned that on and turned that off efficiently. And our failure to do so has led to the mess that we're in now, where states that were lukewarm in their response, were not disciplined, ended up just having a resurgence of disease. We were one of the early states. Our pinnacle was in the month of April, and we filled our hospital. We had to build 2 floors of ICU space. We had 120 people in the ICU, most of them were on ventilators. Death rates that we had not seen ever, a number of people in ICUs we'd never seen, number of people on ventilators we'd never seen. So we were absolutely overwhelmed, and I think that goes for the tri-state area, New York, New Jersey, Connecticut. But we did have a much more disciplined response after the fact. By the month of May, we were using these generic precautions fairly universally. And although we're now in a surge, it's nowhere near what it was back in April. And I feel that folks who have motorcycle rallies with 250,000 people, folks who make fun of mask use, folks who essentially are practicing, in my view, ageism by accepting deaths in the elderly as some sort of necessary price to pay to keep society open. I think that's a false dichotomy. I do think, by the way, that Jay is wildly overestimating prevalence of infection in the United States. Those numbers, you would have to have what you have in Corona, Queens for those numbers to be true, Jay. And I feel like our statewide survey in Connecticut, despite the fact that we had one of the worst epidemics in the country, was about 3% prevalence. So I think it's a false promise that to let the epidemic run wild and all of a sudden you're going to have herd immunity. The only way you're going to have herd immunity is with an effective vaccine at high coverage. The Swedes haven't seen anywhere near herd immunity. Wuhan, China didn't see anything near herd immunity, and I think that's a false promise.
Jay, would you like to respond?
Yeah, so a few things. So first, let me talk about some points of agreement. I completely agree about ageism. I mean, I think that is a completely inappropriate response to say it's okay to let older people die from it. I think one of the main things I've sort of put forward an argument is to protect the older population. I mean, that's the whole idea of focused protection. And the response I've gotten back from many public health people is that, well, just throw up our hands and this isn't possible. In fact, I think it is possible. There's like creative things we can do to protect the elderly or older population, vulnerable population. I'll just give you one concrete example. During the lockdowns, we designated a whole class of workers as essential. 63-year-old people with diabetes were asked to go be bus drivers or Costco clerks, put in harm's way because no thought was given to protecting them. I think this idea that by controlling community spread, we automatically protect the elderly is itself a form of ageism, I think. We have not taken seriously our knowledge about who really is vulnerable in our national response or in our state responses, as a matter of fact. I think, and part of the problem has been this reliance on controlling community spread as a panacea for this, which clearly has failed, which I think is the second point of agreement with me and you, Sten. Let me respond to the estimate I gave between 70 and 100 million. That estimate, so just you can arrive at it a couple of ways. One is the CDC, for instance, in July or August, I don't remember exactly the date, did a seroprevalence study where they estimated there were 10 times as many cases as there were, or infections as there were cases. Now, I think that, again, the testing has gone up since then, so I don't think it's 10 times now, but it was 40 times early in the epidemic, 10 times in the middle, and probably somewhere near 5 times now. If you do the integral, you get roughly what I got. I mean, there's a lot of uncertainty around that estimate, but it's going to be somewhere in the 70 to 100 million range. Let me say another thing about where I disagree. I think, Sten, you talk about herd immunity. I don't know what the herd immunity threshold is. It's very clear there's large numbers of people still susceptible. Herd immunity, all it means is that when one person becomes infected, they spread the disease to at only one or fewer more people. That's essentially what that it's an equilibrium state that comes out of these SIR models. Are we near that? Well, it depends on what the interaction patterns between people are. When interaction patterns change, like they do in the winter, you're going to see more infections. So, you may be in a state where you're spreading fewer people, getting the disease spread to fewer people now, but then as they move indoors in winter, you're going to see spread. So I'm not arguing for herd immunity. It's an end state for this disease, no matter what we do. So it's kind of a red herring. So the issue really isn't let's have a herd immunity strategy where we let it rip. I'm not for that. I've never been for that. What I'm in favor of is protecting vulnerable people, but doing it intelligently, not just by relying on slowing community spread. We can get into like the harms from that, like the efforts to control community spread in a bit. So the only question then to me is, what's the right strategy to protect the vulnerable the best? Either these lockdowns, that's one strategy. These national lockdowns, I think Dr. Fauci just argued in favor of a nationwide policy of essentially like of sharp lockdowns. I know Mike Osterholm has argued for that. Or a focused protection strategy that takes into account differences across the country in the spread of the disease. I mean, some places are seeing very, very sharp spread. I think like Illinois is a good example, the Midwest, and others are seeing much less spread. I think those kind of local responses with an eye toward the focused protection of the vulnerable is the right policy, given what I think of as the steep harms of the lockdowns.
So thank you, Jay and Sten. Let me try to focus the discussion on what I see as kind of areas of where I think we could have a really interesting conversation. So clearly, both of you agree that there's a need to protect the elderly as a vulnerable group. There is certainly a question about how to do so. So Sten, you mentioned the utility of masks, physical distancing, selective closure in high prevalence areas, and preparation for stay-at-home or closures in low prevalence areas. There's been a lot of debate, both in the popular discussion and in the research community, about what evidence there exists that is applicable to justify the efficacy of those strategies. And I'm sure that both of you have thoughts on that. I wonder, Sten, if you could talk a little bit about why you're confident that those measures would be the right strategy for us today and into the coming months, and what evidence do you think we can rely on?
Almost naively thinking that this was an interesting condition, not really appreciating how devastating it would be for our country. I did my own little mask critical review of the literature way back, I don't know, early February. And I found a number of papers that were compelling, that suggested that masks could be very helpful in reducing transmission. It's more of a respiratory viral outbreaks. The data were not from coronavirus as much as they were from influenza, tuberculosis, which is not a virus, obviously, but has some analogous challenges. So I satisfied myself that masks would be a good idea. Physical distancing comes to us from experiments from tuberculosis in the 1930s, classic experiments, all the way to airplane outbreaks, train outbreaks, restaurant outbreaks. 6 feet is not an arbitrary number. It's actually a very justifiable number. And one can see in these closed space outbreaks that a couple of meters makes a big difference, as does the amount of time you are a couple of meters away. So I thought that was also very rational. Hand washing, we can date back to Semmelweis and Lister, and surface hygiene. Air quality is well known. You can date back to TB sanatoria and the outbreaks of tuberculosis in healthcare settings in South Africa during the AIDS pandemic. That we know that, and SARS itself, we know that you can protect. So all of the measures, I thought were clear to us in March. That what was not apparent was leadership. I mean, when Dr. Messonnier, who is the director of the division of vaccines and respiratory diseases at CDC, did her press conference, I think it was February 25th, give or take a day. She's mapped this all out for us, and she was essentially shut down by CDC leadership in the White House. You haven't heard anything from her since. So we had exactly the wrong approach. It almost reminds me of Henrik Ibsen's great play, An Enemy of the People, where Dr. Stockman, the fictional hero of that play, tries to speak out about risk to the community and is just shut down by the political forces. So we did exactly the wrong thing by failing to implement these things efficiently and effectively in communities so that we could shut this virus down early on. And I think if we had shut it down in the month of March with a disciplined regional and national response, we wouldn't be having this conversation today.
Jade, what do you think about these measures, just from a very practical standpoint? Masks, physical distancing. So Sten has discussed the evidence on these, and the need for, I think Sten used the word disciplined response in the use of these strategies. What is your take on the evidence supporting the efficacy of those measures, and what do you think? So it's specifically, what is a focused protection strategy in your view, and what evidence undergirds your proposal? And if you could speak to those other issues that Sten raised, that would be ideal.
Sure. So, I mean, I'm not against any of these things. I think there's some evidence in that case, in those settings for many of those things. But like, I think in the United States, I think it's somewhere on the order of 90% mask use. I mean, it's pretty widespread now in throughout the U.S. Physical distancing is a staple. I mean, especially, and I think those kinds of recommendations are fine. Hand washing, of course. I mean, there's, as Sten said, there's an enormous amount of evidence going back centuries on hand washing. I think all of those are reasonable precautions that we should take in certain circumstances, consistent with the evidence. I don't think that they're enough to stop, or would have been enough to stop the spread of the disease even in February and March. I think the issue is that already in March it was already too widespread in Europe and the United States and the South America for the disease to be stopped by, or to be eradicated. I think the central error in thinking this way is that somehow we could have gotten to zero COVID when it was already impossible in February. The only end state of this it doesn't include zero COVID. We've only eradicated one disease in human disease in the history of mankind. Smallpox and none other. COVID is not going to be eradicated. So the question is how you best cope with it. And I think, again, I'm not against any of those strategies, but I don't think they're a panacea. And if you look carefully at the evidence, I don't think it says that they've been particularly. I mean, they've slowed things down, I think, to some extent, but they haven't been particularly effective evidently in preventing people from dying from it, even though many places have adopted them pretty wholeheartedly. If you look at other countries, you can get a sense of this, right? So Peru has had a lockdown pretty sharply all the way through the epidemic, and yet it's had a huge amount of infection. Belgium has locked down. We've seen places that have tried to lock down, but if you don't start from near zero, these things aren't going to work to eradicate the disease. Let me say another thing about leadership. I think this is also a sort of an overestimated idea in infection control here. The problem isn't leadership. The problem is lack of ideas, lack of good ideas. We've relied only on lockdown, which we haven't had managed to talk about this yet, but they've had absolutely devastating effects. And actually, in many ways, I think has exacerbated the epidemic, made it worse. And also caused its own problems. I think we've relied on that and these other ideas about like mass, physical distancing, so on, as if they were going to solve the problem when they clearly have not and cannot.
Why is lockdown not working, Jay, in your view? And how do we come to that?
Well, I mean, I think there's a few things. One is lockdown can't last very long. Right. So if you think about what we did in March and April, it was at enormous cost, a huge hit in the United States, not just to our income, but also to the physical health and mental health of the United States. But that was true worldwide. In most places, it wasn't, the lockdown itself didn't actually serve to protect hospitals, because most places weren't at risk of hospitals running over in the United States. In fact, the CARES Act, what it did is it sent a lot of money to bankrupt hospital systems around the country, because they were bereft of patients, both COVID and non-COVID patients. So the lockdowns themselves harmed our hospital system's ability to cope with COVID. It harmed our economic, so I'll give you another example. Lockdowns created multi-generational homes. It sent young adults back home to live with their older parents, thus putting people who are more likely to get the disease in contact with people who are really, really likely to, or much more likely to die should they get the disease. The lockdowns created enormous harm to the psychological health of Americans. So for instance, in June, the CDC estimated that 1 in 4 young adults, 18 to 24, seriously considered suicide. Child abuse rates are almost certainly like undetected because schools closed down. There was a study just published in the JAMA Open Network by Dimitri Christakis, who's a pediatrician at University of Washington, who estimates that there were 5.5 million life years lost from school children alone because of the reduction in education. So the idea is very simple. If you reduce education, if you reduce the number of years of schooling, that has long-term lifetime consequences for the health of the kids, right? Including reductions in life expectancy. Yes.
Jay, sorry to interrupt, but so I think you make some very compelling points about the cost of lockdown. But another way of looking at this, and some critics have argued, the problem with our policy is that the lack of coordinated lockdown resulted in longer lockdowns than we otherwise would have had. Like, for instance, what if we had been able to implement national lockdown for a 3 or 4 week period instead of coordinated patchworks of state and city lockdowns, which are fundamentally not able to substantially stamp out the disease? What would your response be to that kind of argument?
Theoretical literature is clear. The lockdowns don't stamp out the disease. All they do is put it off into the future, right? This is a great point for me to transition to another piece of big news that we've had. So last Monday, we heard about Pfizer's vaccine. Recently, we've heard about Moderna's vaccine. Sorry, go ahead. Let me interrupt. So, I think you're talking. Stan wants to talk about March. A lockdown in March would not have eradicated the disease.
But Jay, the reason I wanted to talk about vaccine is that
I know why, Doris, you want to talk about it. I'm going to talk about that in a minute. But
okay.
I just want to complete the discussion about March. It's not failed leadership. It's failed ideas. The idea that a lockdown would have prevented the disease, what would have happened if we had a more severe lockdown, although it's hard to imagine how we would have had an even more severe one than we had in March and April. But if we'd had a more severe lockdown in March and April, the disease just would have been worse in July without it.
Yeah, so I think that's a fair point, and I'm going to let Sten answer it shortly. But I want to turn to this other issue, which is, has the arrival or the promise of very effective vaccines changed the calculus on lockdowns. So, Jay, I think let me just clarify for the audience who might not be thinking 3 steps ahead the way that your agile mind can. So the issue here is that you've argued in the past that lockdowns simply delay the inevitable. That instead of getting sick today, we're going to get sick 3 months from now, 6 months from now, when the lockdown inevitably eases. If, on the other hand, there's a promise of vaccines in whenever it is, March, April, May, June, and it's unclear, but we can discuss that as well. Doesn't that then change the calculus and say lockdowns are now more valuable because they can get us past the finish line when we'll actually have vaccinations?
Yeah, I think it's backwards, right? So every moment that we do a lockdown, we face these absolutely enormous, devastating costs that I've sort of started to outline. I could go on. There's international costs as well, with hundreds of millions of lives at stake, caused by these lockdowns, I think. But let's just leave that. I think the question is, what should you do with the vaccine? Let's say we had it immediately. Let's say in Operation Warp Speed, there's 35 million people that are going to be able to get this as soon as the FDA says yes. The way to use those vaccines is to protect the vulnerable. It's a mechanism, and a great, if the data turn out the way we anticipate, it's a great mechanism for focused protection. That's the right way to use the vaccine, so that older people and other people with chronic conditions or in high-risk situations like hospital workers don't have to face that risk from mortality. That's the right way to do it. In the interim, while we're waiting, we should do focused protection using other mechanisms, because the harm to the lockdown—
So can you actually talk more specifically? There's some audience questions, and I think people are interested in hearing you talk more specifically about what focused protection means. And then I promise Sten has been very patient, and you're going to have a long chance to respond. Go ahead. Last chance.
I think so. Let me be a little more specific then. So focused protection depends on who you are and where you are, right? So nursing homes, I think we were terrible in March and April in protecting our nursing homes. New York in particular, and New Jersey in particular, I think did an absolutely abysmal job with its nursing homes in March and April. I think famously sending COVID-infected patients back to convalesce, even though they were still infectious, infecting the rest of the residents. I mean, I think so. I think protecting nursing homes using masks, social distancing, rapid antigen testing of staff, reducing staff rotation, so that nursing home residents see only a limited number of staffs, making sure that staffs don't work in multiple nursing homes. Making sure that visitors are screened very effectively, or potentially have to see people through distance. I think all of those are really important mechanisms to try to protect nursing homes. In people living at home alone, older people, I think we have essentially abandoned them. We can use the resources we have so that we can deliver groceries to them, so they don't have to go out to Costco or wherever to go to grocery shopping and get exposed. I think mechanisms like that would be really effective for older people living at home alone. For workers, older workers or workers with chronic conditions that put them at high risk, we should use things like the Americans with Disabilities Act, so that employers provide reasonable accommodations so that they don't have to be put in situations that are exposed. You can, like older teachers, for instance, they can help with curricula for younger teachers, or grading with younger teachers and not have to teach in person, whereas younger teachers potentially could teach in person with much less risk. And you can use the ADA or other mechanisms to try to provide those kinds of accommodations.
Okay, thanks, Jay. Sorry to interrupt, but I want to give Sten a chance to respond on a couple of dimensions, because that's a great overview of some of the policies you have in mind. And Sten, in particular, so first of all, feel free to respond to the question of lockdowns in general, or just response. Let's be more general in this. But one thing I'd like to advance, a couple of audience members have asked about lockdown fatigue. So here we are in November, and we have to acknowledge the fact that compliance is an issue with any policy that we pass. So what can we do today that's evidence-based, likely to slow spread, save lives, that actually can be complied with. What are your thoughts on that, Sten?
So in April, the state of Connecticut joined the state of New York and state of New Jersey as the three worst states in the country. Lockdown for us was a desperation effort to slow the overwhelming burden on our hospitals. Yale New Haven Hospital had to create 2 new floors of ICU beds, unprecedented, beyond anything that we'd ever experienced in the past. And that was nothing compared to Elmhurst Hospital in Queens or Montefiore Hospital in the Bronx. Or, I mean, we were lightweight compared to them. So we were really quite desperate to slow the spread. And the work of the faculty at my school showed a superb correlation based on cell phone mobility studies. And you could map the decline of people's mobility to the decline of cases. And we think that that's not well controlled, obviously, but there seemed to be a very powerful ecological association. And in states where one has not seen that cell phone mobility data shift, you've not seen the precipitous decline. So I think it's overstating it, Jay, to say that lockdowns don't work. I think lockdowns, when they are well done, can slow the spread of virus. And why wouldn't they? When Sten and his wife are at home and we're not out mixing, we didn't get coronavirus. So it's very logical that if you reduce the networks and shrink networks of contact, that you can slow viral pandemic respiratory virus spread. I completely understand, and I've written about this, and completely agree that lockdowns have severe negative consequences. And I've been spending a lot of my free time trying to help schools in my region stay open with safety precautions in the school, with testing strategies if the schools can afford it, with a rigor around management and decompressing the schools, having some of the school kids doing Zoom classroom just so you can decompress the school. And we've been doing a pretty good job keeping schools open in this region and trying to mitigate the harms that Jay has been highlighting. So I think we're in a different place in the US. I think we can have selective lockdowns, just as Jay, I think, is implying. We can have regional approaches, but I also think that we can do lockdowns more intelligently. There are many businesses that can stay open. There are many businesses that can pivot to takeout delivery, for example, if you're talking about food service. There are many opportunities to decompress the density of people in a building. You can substantially improve air quality by heating, ventilation, and air conditioning systems, so-called HVAC systems. Use the MERV 13 filters. Increase air exchange to 5 or 6 times per hour. Mix in external air as best you can, at least 20%. And we all know that the outdoor events are safer than the indoor events. So there are many, many more strategies available to us now with our knowledge base than were available to us last March. And I think we can mitigate the economic and social harms, but we can also try to ratchet down transmission with some of these classic, and I think they're more effective than Jay does, strategies for control of respiratory viral spread.
Jay, one last question on this issue of lockdown, and then I want to skip to another topic. But several members of the audience have, and actually Sten himself, Sten has noted overseas examples, for instance, the South Korean case. Some audience members have noted the success that a country like New Zealand has had, others in Asia. So it does seem like there are models out there for controlling community spread. They have relied on various kinds of selective mobility restrictions and so on. But I guess the question is, do you think the United States could follow one of those overseas models that involve some degree of mobility limitation, contact tracing, and tracking? to limit community spread, and why or why not?
So I think that it's curious that so many Asian countries did better than basically Europe, United States, and the Americas. Um, if you look at Africa, the death rate's incredibly low there. It seems like there's some policy invariances because these countries did very, very different policies and yet got the same result regionally. I don't think thinking along the lines of the policy is really the most productive way of, or sort of the most obvious way of explaining this pattern of results. So Japan, for instance, didn't lock down very sharply, and yet it has had a very low death rate. South Korea famously had a contact tracing policy. China had a absolutely draconian lockdown with incredible violations of civil liberties, and yet they end up in the same place. So I don't think
Same place in what sense, Jay?
I mean, they have relatively low number of deaths, right? So I think the issue is not the common explanation can't be the policy. If you want to understand, I mean, I'm not saying policy did nothing. I'm saying that the policy is not the first order explanation if you want to think about it. But there are other explanations that one might jump to, but those are, I think, at this point still.
So which are what are the other explanations you could use? Because it is a stark fact that some countries have
like if you
very well.
It could be different for different places. So I think if you want to understand Africa, you need to look at the age distribution. I think the median age of Africans are 17 or 18 years old, and they die at lower rates if you get infected at 17 or 18, right? So if you want to look at much of Asia, I don't know yet. The literature is not set yet on this, but like there does seem to be pre-existing cross-reactive immunity to other diseases that seem protective, maybe other coronaviruses or who knows? I mean, there's still some other common explanations that.
But wait, why aren't policy differences a better and an Occam's razor style simpler explanation for all of those things?
I think I explained to you why, right, Dries? There are different policies in different countries in Asia, yet they result in the same place.
Well, what I heard Sten say, just to be clear, and Sten, you can, I don't want to put words in your mouth necessarily, but the countries that have engaged in coordinated restrictions and contact tracing.
Let me address that, because I think that also there are countries that have done that have failed, right? So for instance, Peru has had an absolutely draconian lockdown, contact tracing, you name it. Argentina, same thing, and yet the cases and deaths are absolutely high. Peru, I think, is the highest in the world in deaths per million. Belgium, very, very severe lockdown. Germany.
Go ahead, Stan.
To me, one of the cleanest comparisons is to take Sweden on one hand and Norway and Denmark on the other. As a Norwegian American whose parents grew up on the Swedish border, I can tell you that those societies are not vastly dissimilar. And Norway and Denmark took a relatively conservative approach with many more stay-at-home regulations and many more precautions. Sweden famously embraced a sort of philosophy of letting the virus flow, and you have 4 times the death rates in Sweden than you do in Norway and Denmark, and many-fold higher numbers of cases. So I think to say that these classic approaches to viral respiratory control don't work, I think is incorrect. And I think the weight of evidence is that with the greater discipline, one can enforce these approaches and adhere to them, the better chance we have of controlling the pandemic such that we can sort of reopen society normally. Now, we're running out of time, but I'll tell you that the vaccines are immensely promising. We all know that. It's almost a dream come true that we would have 90% effective. And the fact that the spike protein, antibodies to the spike protein seems to be an effective correlate of protective immunity bodes well for a whole family of other vaccines that are using completely different strategies rather than the RNA approach. So if we can overcome vaccine hesitancy, if we can produce enough vaccine, just the volume of vaccine, we may be in a very different place a year from now or perhaps 2 years from now than we are now.
Well, thank you, Stan, and I think that's a perfect.
Let me respond, actually.
If you can respond in 15 seconds, you can
Okay, so
respond.
Sweden did a focus protection policy after April. It's failed in April to protect its nursing homes and corrected. And if you look at the data for deaths from Sweden now, it's very, very low relative to the rest of Europe. The problem with Sweden early on was a failed policy of focus protection. And the success of Sweden now has to do with implementing better focus protection ideas.
Okay, there's the 15 seconds. Stan, I'm going to give you 15 seconds to respond, and that'll be the last word. And thank you very much to both of you.
If this were easy to solve, Jay and I and Darius would have already solved it. I mean, let's be honest. This is immensely complex. We lack effective control groups for many of the inferences that we're drawing. There you go. And thanks, Jay, and thanks, Darius.
Thank you, Sten. Thank you, Jay, on behalf of the Schaefer Center. We're so pleased you took the time to join us today. And thanks to everybody who joined us via Facebook and Zoom. And we look forward to seeing you again at our next seminar. Thank you very much.